Imagine living with a condition that causes just intense, unyielding physical pain and, actual structural changes to your body.
Yeah, it's a terrifying thought.
Right. And then waiting half a century, literally 51 years before a doctor finally looks at you and says, this is what you have.
51 years. It's just staggering.
I mean, that is a real case study we are looking at today for this deep dive. 51 years of severe symptoms, misdiagnoses, and, well, just silent suffering.
And honestly, the broader statistics, they aren't much more comforting.
No, they really aren't.
When we pull the data from the British Association of Dermatologists and the European Guidelines for the Management of Vulval Conditions, the average diagnostic delay for vulvar lichen sclerosus is still hovering right around 4.6 years.
Which is just a massive window of time.
Exactly. It's a huge window for a chronic immune-mediated inflammatory disease to just, progress completely unchecked. It's actively altering a person's anatomy during that time.
Right. Which brings us to the core of what we're doing here today. Welcome to the deep dive, everyone. We are taking that whole stack of medical guidelines and clinical case studies, and we are zeroing in on one incredibly specific but crucial focus.
Yeah, the diagnosis.
Exactly. What tests actually confirm a lichen sclerosus diagnosis? I mean, if you are navigating this landscape, if you're dealing with the severe itch, the tearing, the progressive scarring of the anogenital region, how do medical professionals strip away the guesswork?
How do they actually prove it's there?
Yes. So before we get into the heavy machinery of testing, could you just give us a quick, 30-second primer on what LS actually is for anyone who might need a refresher?
Sure, absolutely. Yeah. So lichen sclerosus, or LS, is an inflammatory dermatosis. It predominantly affects the anogenital region.
Right.
And it often causes severe itch, actual pain, and architectural changes to the skin. It basically destroys the tissue structure over time if it's left untreated.
Okay, so with something that severe, you'd expect modern medicine to just, immediately hook you up to a complex machine or run some massive blood panel to get a binary yes or no answer.
Right, you'd think so. But looking closely at these international guidelines, the primary diagnostic tool for lichen sclerosus isn't a machine at all.
Wait, really?
Yeah. In classic cases, LS is defined as a clinical diagnosis, which means medical professionals are confirming it primarily just through the naked eye.
That is wild. But I guess reading through the visual criteria they use, it's almost forensic.
It really is. They aren't just looking for general irritation or a generic rash.
Right. They are scanning for a highly specific constellation of visual markers. And the most prominent one mentioned across basically all the sources is the color and texture change.
Exactly. The skin transforms. It develops these pale ivory or porcelain white patches.
Porcelain white, that's such a specific descriptor.
It is. And that color change is the hallmark of the deeper structural damage happening below the surface. But clinicians are also assessing the texture.
Right, because it's not just the color.
Right. The epidermis, which is the top layer of skin, it becomes atrophic. It thins out so dramatically that it loses its normal elasticity.
This holds, right.
Exactly. It takes on this wrinkled, incredibly fragile appearance. The standard medical comparison, which is super vivid, is that it looks remarkably like cigarette paper.
Cigarette paper, wow. That really gives you a sense of just how thin and easily damaged we're talking about.
Yeah, it's paper thin.
And the sources also highlight the geographical distribution of those patches, right?
Yes, the pattern is key.
In vulvar and perianal lichen sclerosus, those white atrophic plaques frequently form a really distinct figure-of-8 pattern.
Right, looping around the vulva and then extending down to encircle the perianal area.
And within that compromised tissue, doctors are also looking for signs of something called purpura or ecchymosis.
Yeah, purpura. Those are essentially microhemorrhages.
Like tiny bruises.
Exactly. Because the skin has lost its structural integrity and, like we said, thinned to the consistency of tissue paper, the underlying capillary beds lose their protective cushioning.
Oh, that makes sense. So there's no padding left.
None. So just normal daily movements, literally the sheer force of walking or just slight friction from closing, that becomes enough to rupture those tiny blood vessels.
Jeez. So seeing those localized tiny bruises in that specific figure-of-8 distribution, that's a massive visual red flag for a clinician.
Huge red flag.
It's kind of like an art appraiser authenticating a painting, you know, just by looking at the brush strokes and the specific texture of the canvas.
That's actually a great analogy.
But I do have to push back a little here.
Sure.
Because human eyes have limits, especially in the early stages where the skin might just look, know, generally inflamed or red.
Oh, absolutely.
So if the symptoms can overlap with so many other things, like eczema or severe thrush, isn't relying just on visual inspection a bit risky?
It can be, yeah.
Yeah.
Which is why there's a next diagnostic step up before they do any invasive testing. It's called dermoscopy.
Dermoscopy, so a specialized microscope.
Yeah, basically a non-invasive skin microscope. A dermatoscope uses polarized light to cancel out the surface reflection of the skin.
Okay.
And that allows the clinician to look just slightly deeper into the dermal layers. They're looking for the microscopic precursors to that white scarring.
So what exactly are they seeing through the scope?
The guidelines describe finding these structureless, whitish, and yellowish patches.
Structureless.
Yeah. Biologically, that is the collagen in the derm is beginning to homogenize. It's losing its healthy woven structure and basically fusing into a uniform block of scar tissue.
Wow, so you can literally see the scarring starting to form.
You can. They also look for altered vascular patterns, like
Mhm.
irregular linear or dotted blood vessels.
Right, because the blood vessels are getting messed up.
Exactly. And they look for something called comedo-like openings.
Comedo-like, like blackheads.
Kind of. They look like tiny plug pores where the hair follicles and the sweat glands are actually being choked off by the spreading sclerosis.
Oh, wow. So they are essentially confirming the disease by reading the microscopic architectural damage.
That's exactly it. But to your earlier point, relying purely on visual inspection, even magnified, it still carries inherent risks.
Right, because untangling LS from contact dermatitis or psoriasis just by looking
Yeah.
can be a dangerous guessing game. So when do they actually bring out the heavy testing machinery?
Well, this brings us to the threshold. The European guidelines and the British Association of Dermatologists are very, very clear on when to cross the line from just looking to actually cutting.
The biopsy.
Right, the biopsy is the definitive diagnostic test. But the guidelines explicitly state it is seldom necessary if the clinical picture is classic.
Okay, so they don't want to cut unless they have to.
Exactly. But there are absolute must-biopsy scenarios.
Like what?
The first is simply diagnostic uncertainty. If the presentation is atypical or, if the disease appears in extragenital areas.
Like on the trunk or the breasts?
Right, because in those areas, it can perfectly mimic a totally different sclerotic skin condition called morphea. So in that case, a biopsy is mandatory to tell them apart.
Makes sense. What if someone is being treated but it's just not getting better? Does that trigger a biopsy?
Yes, that's the second major trigger, treatment failure. The first-line gold standard treatment is an ultra-potent topical corticosteroid, usually clobetasol propionate.
Right.
If a patient applies that correctly for a designated period and the architecture just continues to destruct, the doctor has a biopsy. They need to find out if they're dealing with a super resistant strain of LS or if it's an entirely different disease masquerading as it.
But there is more dangerous trigger too, right?
Yes. The most critical trigger for a biopsy is the suspicion of neoplastic change.
Meaning precancerous or cancerous developments.
Exactly. Lichen sclerosus carries an estimated 3 to 5% risk of developing into vulvar intraepithelial neoplasia, which is known as VIN, or fully developed squamous cell carcinoma.
Okay, let's unpack the mechanics of that cancer risk for a second, because it speaks directly to why doctors are so incredibly vigilant about, like, persistent ulcers or sudden thickened lumps.
Yeah, it all comes down to the mechanics of chronic inflammation. In untreated lichen sclerosus, the immune system is relentlessly attacking the basal layer of the skin.
It's a constant battle.
Right. And the body's constantly trying to heal that damage, so it's forcing the skin cells to rapidly divide and rebuild the tissue over and over and over again.
And every single time a cell divides, there is a microscopic chance for a copying error in its DNA, right?
Precisely. Chronic inflammation is basically spinning the roulette wheel of cellular mutation at, 10 times the normal speed.
So eventually an error occurs that doesn't get caught by the body's defenses.
Yeah. And you have a mutated cell that begins to multiply out of control, leading to squamous cell carcinoma.
So that constant cycle of destruction and hyper-repair is basically the engine of the cancer risk.
It is. And that is exactly why any ulcer that just refuses to heal or any hyperkeratotic area that suddenly thickens up, it demands an immediate biopsy.
And there's one more specific scenario mentioned in the sources, right?
Right.
Regarding circumcisions.
Oh, yes. During male circumcisions, the guidelines say the removed foreskin should basically always be sent for histology.
To check for LS.
To confirm LS, but more importantly, to exclude penile intraepithelial neoplasia, or PINE, which is the male equivalent of those precancerous changes.
Okay, so let's talk about the actual physical reality of this test, because the guidelines are hyper-specific about the geography of the biopsy.
They have to be. Getting the right tissue is everything.
Right. So a doctor uses a small cylindrical tool, which, reading about it, it's essentially a tiny medical apple corer.
Yeah, that's exactly what it looks like.
They use this 4 millimeter punch under local anesthetic to punch down through the epidermis and dermis, but they must take that tissue from the most active sclerotic area at the margin of the disease.
Yes, the margin is crucial.
Because they explicitly warn against biopsying an ulcer itself. Right. Why is that?
Because taking a core sample from the center of an ulcer is diagnostically useless.
Really? But isn't that where the worst damage is?
It is, but that's the problem. In an ulcerated area, the entire upper architecture of the skin has already been obliterated. The tissue is necrotic. It's dead.
Oh, I see.
So if you send that dead tissue to a pathologist, they can only confirm that, well, the tissue is destroyed. They can't tell you why it was destroyed.
So to diagnose lichen sclerosus, the pathologist needs to see the active battle lines.
Exactly. And they need an intact margin where the disease is actively invading healthy tissue.
Okay, so once they get that perfect 4 millimeter cylinder of skin, it lands on the pathologist's desk. They slice it incredibly thin, stain it, and put it under a microscope.
Right.
And the histopathology, meaning the microscopic structure of LS, is fascinating because it leaves this very specific layer-by-layer trail of destruction.
It's very distinct. If we break it down layer by layer, starting at the very top, the epidermis, the pathologist expects to see a structural contradiction.
A contradiction? How so?
They look for hyperkeratosis, which is a massive thickening of the outermost layer of dead skin cells, the stratum corneum.
So the very, very top is getting thicker.
Right. But immediately beneath that thick roof, the living cellular walls of the epidermis are profoundly atrophic.
They're dangerously thin and flattened out.
Exactly. Thick dead layer on top.
Yeah.
Dangerously thin living layer right below it.
And then we hit the critical junction between that thin epidermis and the deeper tissue. The medical term used in the sources is basal cell liquefaction, or degeneration.
Yeah, basal cell liquefaction. Think of the basal cells as the mortar holding the bricks of the epidermis to the foundation of the dermis below.
Okay.
The inflammatory immune cells are actively attacking and dissolving that mortar. As that basal layer liquefies, the structural integrity of the skin just completely collapses.
Wow. So that is why the skin of an LS patient blisters and tears and splits open so agonizingly easily.
Yes, there is literally nothing anchoring the top layer to the bottom anymore. The mortar is gone.
That is horrifying. And then moving deeper into the dermis, the pathologist looks for the most definitive signature of all, right? A broad band of hyalinization.
Yes, this is the visible aftermath of the damage we were talking about earlier with the dermatoscope. The normal, flexible collagen fibers in the dermis have been completely replaced by this homogenized, glassy, sclerotic tissue.
It's basically a dense wall of scar tissue right under the surface.
Exactly. And just beneath that zone of hyalinization, the pathologist will see a thick, band-like infiltration of lymphocytes.
And those lymphocytes, those are the white blood cells. They are the actual immune attackers driving this entire process.
They are the invading army.
So under the microscope, the pathologist is looking at the invading army of lymphocytes at the bottom, then a battlefield of glassy scar tissue above them, a dissolving layer of mortar, and a thinned-out, fragile roof.
That's a perfect way to visualize it. And the presence of that entire vertical sequence is what allows the pathologist to stamp the report with a definitive confirmation of lichen sclerosus.
But wait, if someone has been diligently applying those ultra-potent steroid creams for months trying to get some relief, and then the doctor decides to biopsy, doesn't that mess up the test?
Yes, it absolutely does. The sources explicitly warn about this. The steroids can completely ruin the test.
Because the creams are actually doing their job.
Exactly. Topical corticosteroids are incredibly effective at suppressing local immune activity. If the cream has successfully beaten back that invading army of lymphocytes and reduced the inflammation, those classic histopathological markers start to fade.
So the pathologist looking at a heavily treated biopsy might just see, like, some homogenized collagen, but no active lymphocytes and no basal liquefaction.
Right, and that results in a frustratingly inconclusive test.
Which means, if it's clinically safe to do so, a patient might actually have to endure a washout period, like stopping their medications so the disease flares back up just enough to be visible under the microscope.
Yeah, it's brutal, but sometimes necessary for a definitive answer.
Okay, so what happens when the biopsy clearly shows severe tissue-destroying lichen sclerosus, but the clinical presentation was so severe that the doctor still suspects there might be underlying cancer?
That's when the pathologist has to take the diagnostic process to a molecular level using immunohistochemistry.
Right. And one of the case studies we reviewed, the one from an Indonesian medical journal, detailed this exact scenario.
Yes, that was a fascinating case.
The patient presented with massive aggressive ulcerations. Visually, it looked terrifyingly like advanced cancer. So the lab had to use specific chemical stains on the biopsy tissue to look for two specific protein markers.
P16 and P53.
Right, P16 and P53. Can you break down why they look for those?
So this is where the testing becomes incredibly sophisticated. The P16 protein is heavily utilized as a surrogate marker for HPV-related squamous cell carcinomas.
Okay, so if P16 overexpresses, it highly suggests an HPV-driven cancer.
Exactly. But in this specific case study, the P16 was completely negative.
But the P53 marker came back slightly positive, right? And at first glance, a positive tumor marker sounds really alarming.
It does sound bad, but you have to understand the biological role of P53. It's often called the guardian of the genome. It is a tumor suppressor protein.
So it's one of the good guys.
Very much so. When a cell's DNA is damaged, say, by the constant inflammatory attack of lichen sclerosus, P53 rushes in to halt cell division. It tries to either repair the DNA or force the damaged cell to self-destruct before it can turn cancerous.
So if there was a massive, overwhelming presence of mutant P53, that would indicate a cancer where the guardian has basically failed and gone rogue.
Right. But a slight patchy positivity, which is what they found, that's actually known as a wild-type reaction.
A wild-type reaction.
Yeah, it is the microscopic evidence of the body's security guards actively doing their job in real time. That slight P53 activity proved that the DNA was under severe stress from the inflammation, sure, but the cells were successfully managing the damage without becoming malignant.
Oh, wow. So that molecular tiebreaker allowed the medical team to definitively rule out cancer and confirm a diagnosis of just severe ulcerative lichen sclerosus.
Exactly. It's incredible how deep the testing goes to find a definitive answer.
It really is. But reading through the broader diagnostic guidelines, confirming LS is actually only half the battle, isn't it?
Yeah, unfortunately.
Because lichen sclerosus rarely operates in a vacuum. A massive portion of the diagnostic process is actually about ruling out imposters. It sounds like diagnosing LS is sometimes a game of guess who, you have to knock down all the other possibilities first.
It is a vital step
Yeah.
because secondary infections heavily complicate the clinical picture.
Right. So what are they looking for?
Well, a clinician will routinely take microbiology swabs, high vaginal swabs or skin swabs from the affected area.
But they aren't swabbing for lichen sclerosus, right?
No such swab exists. They are testing to exclude overlapping pathogens like Candida albicans, which causes thrush, or Staphylococcus aureus.
And the mechanics of the disease make these secondary infections almost inevitable, don't they?
Yeah, they really do, because the intense, maddening itch causes patients to scratch, usually in their sleep when they can't control it.
And that mechanical scratching tears the already fragile cigarette paper skin.
Exactly, which creates microscopic entry wounds for everyday bacteria like staph. So suddenly the patient is dealing with a fierce bacterial infection on top of an autoimmune flare-up.
And the infection alters the visual appearance, making the tissue redder, more swollen, masking the underlying LS.
Right, so doctors have to swab, identify the secondary bacteria or yeast, and eradicate it just to get back to the baseline disease.
Okay, so that handles the local area. But then the guidelines mandate drawing blood. We are talking about a localized skin condition, yet the diagnostic workup demands a systemic blood panel. Why blood tests for a skin condition?
The biological link here is fascinating, and it's a crucial piece of the puzzle, particularly for women with lichen sclerosus. The sources note a profound association between LS and systemic autoimmune disorders.
The guidelines specifically flag thyroid function, right?
Yes. Doctors are testing TSH levels and checking for thyroid autoantibodies. They're also testing ferritin levels to check iron stores.
And screening for pernicious anemia, too, which is an autoimmune inability to absorb B12 and looking for markers of vitiligo.
Right. And the reason for this extensive blood work lies in how autoimmune dysfunction operates globally within the body. Lichen sclerosus is driven by an immune system that has lost tolerance for the body's own basement membrane proteins in the skin.
It's misidentifying self-tissue as a threat.
Exactly. And once the immune system's programming develops a glitch in recognizing self from invader, that error tends to cascade.
So if your body is willing to attack the skin, it might just start attacking other organs too.
Exactly the case. If circulating autoreactive T cells are willing to attack the epithelial tissue of the vulva, there is a statistically significant chance that the immune system will also generate autoantibodies targeting the glandular tissue of the thyroid.
It's a systemic breakdown.
Right, so identifying a sluggish thyroid or pernicious anemia through blood work not only treats a co-occurring illness, but it strongly reinforces the autoimmune profile of the patient. It aids the overall clinical picture of lichen sclerosus.
That makes a lot of sense. Now, there's one final piece of the elimination puzzle that dermatologists use, and it highlights a fairly cruel irony of treating this condition: patch testing.
Ah, yes, patch testing. This is utilized if they suspect a secondary allergic contact dermatitis.
Oh.
Clinicians apply small grids containing dozens of common chemical allergens to the patient's back, leaving them there for several days to see which ones trigger a localized immune response.
So, you would think if a patient is diagnosed with LS, prescribed an ultra-potent steroid ointment, and comes back 3 weeks later with red, blistering, significantly worse symptoms, the logical conclusion is that the disease is aggressively resisting treatment.
That would be the assumption, yeah.
Mhm.
But the patch test exists to separate disease progression from iatrogenic harm.
Meaning harm caused by the medical treatment itself.
Right. That patient might not be suffering an LS flare-up at all. They might have developed a severe localized allergy to a preservative like propylene glycol, which is used in the base of the steroid cream itself.
Oh man, so they are allergic to the very vehicle delivering their cure.
Exactly. The patch test confirms the allergy, allowing the doctor to simply switch the medication to an ointment base without preservatives, rather than mistakenly ramping up the strength of the steroids or putting them through another painful biopsy.
The entire diagnostic framework, the visual mapping, the molecular staining, the autoimmune blood panels, it's all designed to corner the disease by eliminating every single other variable.
It is a massive multidisciplinary effort.
Yeah, just summarizing this journey, we have the clinician relying on visual hallmarks like the figure-of-8 distribution in purpura. We have the dermatoscope searching for homogenized collagen.
We have the 4 mm punch biopsy seeking out the liquefying basal layer and the invading lymphocytes.
We have the molecular stains hunting for mutant p53 proteins. And we have the swabs and blood work ensuring that staph infections and thyroid disease aren't muddying the waters.
And, executing that gauntlet of testing accurately and swiftly is really the single most important intervention a medical professional can make.
Because it unlocks the treatment.
Right. Getting that confirmed diagnosis unlocks access to those potent topical corticosteroids, which, when used early and effectively, halt the active inflammation and prevent the irreversible architectural destruction of the tissue.
Which I think brings us full circle back to that staggering statistic we started with today, the 4.6-year average diagnostic delay, the 51-year case study.
It's hard to forget those numbers.
Right. And if we know that the earliest, most powerful diagnostic tool for this condition isn't an MRI machine, but simply knowing what to look for on the surface of the skin, it raises a really profound question.
It really does.
If the primary diagnostic tool for lichen sclerosus is just visual recognition, how much could we shrink that 4.6-year delay and the silent structural damage it represents? If patient self-examination guidelines and basic visual awareness of these symptoms became as commonplace as checking our bodies for odd moles, if we simply learned what to look for before the microscopic damage ever begins.